Hi, Paul. How you doing?
Good, how are you?
Good, good. Thank you for presenting. And then, so yeah, we'll give everyone to like 1:05 till everyone sort of signs in, and then I'll introduce you, and then you can take over after that.
Okay, sounds
Okay.
good. Let me put in presenter view.
Hey, Paul.
Hey, how's it going?
All right.
Good.
Just got a hello from Aki this morning.
Yeah. We were talking about your interception paper briefly during our morning review.
Definitely not my paper, but
Yes.
still a good one.
Yes.
Well, it's funny. I was in a meeting the other day with another group of POCUS people, and we were talking about the relative merits and weights of all the different applications and why something should rank higher than another, talking about things that are like surgical and timely, need a decision quickly, and how come we never put testicular torsion on any of these things?
Soon. Yes. I'll send you an email with a little bit of IRB stuff later this evening.
No problem. I'm gonna turn my camera off so I don't look gross eating myself.
All right.
All right. Good afternoon, everyone. Thank you for joining today. Today we have Paul Khalil joining us from all the way from Kentucky, who's going to be presenting this week. Thanks again for Paul for presenting again.
Thank you. Alrighty. So my first couple cases are going to be directed more towards the PEM fellows. I know the Yukon fellows are on board, so let's get started. So my first case is a 16-month-old male who comes in for a skin infection to the gluteal region. It's had a couple days of swelling and induration. I got presented by one of my interns saying, yeah, this looks like an abscess. So let's throw some EMLA on and do an IND. So I'd say let's get some imaging first. And this is what it looks like. And what do the PEM fellows think? Should we cut this or not? I'll play it again for you. Would any of the PEM fellows out there cut it? So this one is a cellulitis. And here's a little bit of a better picture of it close up. I borrowed this second picture, but it's cellulitis and it's cobblestoning and it's thickening of the subcutaneous tissue. Remember that you can't differentiate edema from other causes. My second case is kind of along the same lines of another gluteal skin infection, except now it looks like this. And so throw a little bit of color on. No color flow to it. So, and this is a little swirl sign. So this is an abscess. Same presentation, same age group. This kid got EMLA, a little bit of nasal versed, and he was drained. So always throw an ultrasound on before you cut. And this is a case I always like to throw in when I'm doing soft tissue skin infections. This was published a year or two ago about a case of a patient that had a foreign body to the foot that was removed, and was, when they threw the color on before they drained it, was actually a pseudoaneurysm. So this is just a couple quick intros to soft tissue skin before we go into a couple more interesting cases. So my first case is a 4-year-old male who was initially seen at an outside hospital that had a lump under his axilla. They did the basic oncological labs that were all normal, the LDH, uric acid, CBC. They did a consultative ultrasound that showed that it was lymph nodes. He had a few little scratches on his hand, and there were some kittens that he had been in contact with. So they sent a Bartonella panel as well and started him on azithromycin. He later came to our the main ED in our town, our PED, where he had this presentation. Mother said that he hadn't been able to take any of the azithromycin. He kept spitting it out, and the area had started to grow and swell. At that point, the Bartonella panel had come back positive, so he had a diagnosis of cat scratch, and this is what it looks like. So this is the first picture. And then the second picture with flow on it actually shows the vascular hilum right here going up. So that's how you know it's a lymph node. But when I saw him, we decided to admit him. They put him on IV azithromycin, watched him, and it seemed to improve after his course. He then came back about a week later because mom said that while it had initially gotten better, that it had continued to, or had started to worsen. And sorry. This is what it looked like at the second visit. So we'd consulted infectious disease and surgery after we got some ultrasound images. And you can still see there is that vascular hilum, but there is an area around it that became suppurative. So you see the swirl right here, the posterior enhancement behind it underneath. And so surgery took him to the OR. The cultures he was initially put on clindamycin as well to cover any sort of staph infection. And his cultures actually came back negative. So you can have lymph nodes that become suppurative after with cat scratch disease. And it was just kind of interesting to see how he progressed over his coming back to the ER a couple times.
Paul, would you let's say that you saw him that second visit the first time, would you have trained that yourself?
The second time he saw me, because I would not. Anytime that it's around a lymph node and in the axilla, I don't know. With that vascular around it, I wouldn't feel comfortable.
Would anyone else train that? I'm just curious.
So I haven't stuck needles in necks, and it's out of MDI, but when I see surgery do it, I often wonder why I don't, because they tend to come to the bedside plus minus any sort of EMLA or Lido, and then just do essentially like a needle aspiration of these things.
Yeah. I have gone after these a few times. Groin, axilla. I had an interesting one kind of the back of the neck. Just depends on what else I can see around it. If I feel confident I'm not seeing any badness.
And Matt, did you do a needle aspiration, or you just went after with this simple incision drainage?
Probably the most elaborate one I had was a nice big groin node that had clearly just kind of exploded. It was the same sort of case. It was a Bartonella positive that wasn't getting better on antibiotics and had a clearly like large fluctuant spot and a big pus pocket to it. Now we just did an actual full-on like scalpel based IND with a vessel loop into it because it was a huge pocket and well away from the vessels. Axilla, I've usually tried to be a little more minimal, more like a quick like in and out 11 blade usually.
You do it ultrasound guided, or you just find the pocket and then go where you see the pocket?
Usually just like static guide, just find the pocket, make sure that I know there's nothing around. I found like they have typically been so robustly juicy that I would have to get really aggressive to otherwise get something bad.
So Paul, I do have a question about these clips that you're showing, because the one that's right in front of us, this doesn't even look like a lymph. So there we go.
Yes.
So I would love to coin the term the ovarianization of the lymph node to describe the early stages of liquefaction necrosis, because you get these very chocolate chip cookie looking lymph nodes that almost look like an ovary with peripheral follicles, except it's not peripheral follicle, it's little islands of necrosis. So this looks like a lymph node with that, but then that clip, that video, or whatever was just up, there we go.
Yeah.
This doesn't look, this just looks like it had
Yeah.
fluid cavity.
Yeah, it was pretty extensive.
So were you seeing the lymph node and then this like secondary structure, like peripheral to it?
Yeah, so this was the lymph node, and then right here is where you follow it, and that is kind of behind it.
So that's interesting. So, I mean, with a lot of these things, you don't just have a singular lymph node, there's a couple of them. So it looks like you still had some adenitis, early necrosis, and then, this other thing.
Yeah.
So this one, I think we would probably feel like a lot more comfortable going into, because there's clearly not going to be anything vascular like in this footprint.
Yeah. Makes sense. Any other thoughts on this one? Okay, I'll go on to the next case. And this, just for the fellows, is what lymph nodes typically look like, with a nice hilum through the middle before there's any changes. So my next case, and I have a couple different patients with the exact same presentation that I'm showing, just different angles of it, was a 4-year-old female that had URI symptoms, had a big swelling to her right side of her face, right over the angle of the mandible. So initially, the presentation was concerned for a lymph node, but this is what I found when we threw our ultrasound probe on. And you see here this ductile structure right here with little areas in between that looks like a pomegranate. And you see that the tissue is actually pretty swollen looking and edematous. So throwing the color on again. Another example. One more. And the next one's more of your classical, even though it's not the full view of it, of the pomegranate sign. And maybe even a tiny sign right there. So this is a case of keratitis. And this is what a normal parotid looks like. Less inflamed, not pomegranate looking like. And in kids, these are usually virally induced. And with the right story, it's really quick to get these patients in and out of the ED once you throw the probe on, instead of before I did POCUS, we'd send them to radiology and wait for them to come back, and significantly reduces the time. And I only found one case in the pediatric literature that was from pediatric emergency care last year that they described it as the pomegranate sign. And with kids, I feel comfortable sending them home with just supportive care and secretagogues.
Hi guys, I'm Rosemary. We came up with that sign.
Yeah.
Yeah, that's my paper.
Oh yeah, there you are at the end.
Yeah.
I see ya.
Yeah, exactly. It wasn't noted before, and actually my co-author Carrie Ng was like, how about we call it that? And I was like, yeah, totally. It totally looks like that. So there you go.
Yeah, it really does. And when you describe it to trainees after you tell them that it looks like a pomegranate, it makes sense.
Super. Good to see it.
Yeah. Very cool.
My follow-up question would be, aside from like Rosemary, obviously, how does everyone else feel? Like, do they feel comfortable like seeing that and diagnosing that, and if they use POCUS to diagnose keratitis, and then be confident without sending them to the radiology ultrasound?
I don't think I've ever sent this to radiology.
I did one last week that I did myself, and it just clinically, it definitely looked like keratitis. I wasn't too worried about what I actually saw in the ultrasound anyways. And then I just compared to the other side, and it's like, oh yeah, this is the parotid and it's swollen. So I think it was pretty straightforward.
Yeah, I agree. I feel like this is one of the very low hanging fruit for us to snip off and not have to send to rads, because when it's there, it's pretty obvious.
Yeah. Yeah, I agree. I think it's one of the ones that, and it saves a lot of time. You get the good story from the resident, you bring the machine in, and you get them out 10 minutes later.
Is there anybody still ordering like EVV titers or pumps?
No, I do similar to Paul does. I just send them out tell them to eat sour stuff and take some NSAIDs, as long as there's, not like pus at the, infraoral, or they've got like redness and stuff over top. Although I had a colleague recently who I was reviewing a fellow image, and they're like, oh, I had a great keratitis. And I looked, and they admitted the kid for IV antibiotics. And I was like, why? So there's clearly some variability.
Yeah.
The kid that I saw last week, I kind of offered mom's testing the mom, hoping that she would say no. And you know, because I don't know, I feel like our ID tells us we should do that. But then it's like, but it's a virus. So I told her, I was like, well, it's some kind of virus. Do you really want a blood draw to tell which one? She's like, no.
See if anything is in this chat. No labs, no labs. Yeah.
And for me, years and years ago, I had an unusual case where there was actually a stone in Stensis duct that needed ENT to take to the operating room. I don't know exactly what they did, if they did a little stent or came in from the inside of the mouth or what. But that's like the rare etiology. And I can't, it was such a long time ago, I can't remember the specifics of the case or the age. But just to keep that in the back of the mind, if you see like a very dilated duct, you know, running within the parotid gland, just in that case, I would have Raids take a look.
Yeah.
I think in this case report, actually, there was a stone and there was ENT follow-up, outpatient, but not admission. I'm fairly certain that's what I'm remembering.
Some of the adult people, I think it's more common to have stones in adult, and they say that they'll just flick the stone out because you can sometimes see it at the edge of the, and so when you look inside their mouth. But I've never had one where there's a stone that was obstructing. Cool. Any other thoughts before the next case? All right. So the next case, yeah, I don't know if anybody knows what this is, but this is the Pride of Louisville. This is Churchill Downs, and that's where the Kentucky Derbies ran every year. And you notice that lots of people with big hats. And that brings me to my next case, which was a 12-year-old girl who accidentally stabbed herself in the arm with one of the hat's needles, which is what keeps the hat in place in people's hair. And she initially went to her pediatrician. It looked like a little bit of cellulitis. And then she went to an outside emergency room where they did an x-ray, and they were worried about, they were worried that she had failed outpatient therapy. They didn't make any mention of those air pockets right here. So I got the ultrasound, and this is what I found with ultrasound, is that there was all of this dirty shadowing from the air. I called surgery, who evaluated the patients and agreed that this patient had neck fasciitis, and she wasn't ill appearing, but she definitely had air on both her x-ray and her ultrasound. And there's even a little bit of fluid, it looks, above the deep fascia, but the big convincing thing was the air that was in the tissue. So surgery took her to the OR and did an IND. And it has been described in this next paper, a prospective study where they looked at 62 patients, 17 who had neck fasc, and found that ultrasound was 88% sensitive and 93% specific. Any questions on that one?
Are there other ultrasound findings of neck fasc that they mentioned aside from like your cellulitis findings and then the air?
So they will sometimes, they'll say that there's 4 millimeters of fluid above the deep fascia is the other thing you can look for.
And maybe not related to neck fasc, but if people are looking for like a good teaching image for how to look at or what to see with sub-Q air, every time you do a digital block, you get a little bit. So if you just do an ultrasound after your block, you'll find some sub-Q air.
Mm-hmm. Yeah, definitely. And speaking of blocks, I'm going to go on to my last case, which I did my residency in PEM fellowship in Florida. And we'd have patients that came into the ED after stepping on these little guys or seashells or whatnot. And they'd get little pieces of the shells or whatever crustacean they stepped on the bottom of their feet. The case that I'm going to show you is a little bit different. This was a 15-year-old female who was outside feeding her dog and stepped on the cage, and it got embedded in her foot. Her father cut the dog cage and brought her in. So what I'm going to be talking to you guys about is the posterior tibial block, which I think is really helpful after having tried to numb the entire bottom of the foot before. So there are so you're blocking the posterior tibial nerve. And when you're doing it, and I borrowed this image from Highlands, is you look at the medial malleolus, you have the tibial artery and the tibial nerve running behind it. And there are two ways to approach this. This is a picture of the anatomy close up with the vasculature, the medial mal and the nerve right here. The two ways to approach it are either in plane or out of plane. I generally do these in plane. Fred Warkentine, my colleague, usually does these out of plane. And so you find your landmarks, and you got to make sure if you are doing it in plane that you do not stab the Achilles. And so this is what the anatomy looks like, as you've got your vasculature, you've got your nerve right here. And I don't have a great image of the needle in either of these, but here is the out of plane approach. Our needle is coming from here. You see a little bit of the movement, and we are right above the nerve. So we've injected the anesthetic below and then come back out, or come backwards a little bit and inject it above. And you can see the anesthetic going in. The other approach is the in-plane approach, which is you don't have to worry about running into the Achilles, but you also don't see your needle. Here is an image of the second anatomy. And you can see the nerve, you can see a little bit of the needle coming in right here. So you don't always see your needle in the out of plane. And then you see the anesthetic going in kind of from the side, and it fills the space. And Matt did a paper on this semi-recently. So I think they work. It helps a lot to anesthetize the bottom of the foot. That doesn't always get good anesthetic, particularly if there's multiple spots you're trying to go after. Any thoughts or questions on that one?
There's a couple of comments on the chat, Paul. So Rahul Shah says, do they seem to recommend bending the needle when approaching the in-plane to avoid the Achilles tendon? And if anyone has tried that.
I actually haven't tried that, but that would make sense. We have a small linear probe that has a smaller footprint, so I can get pretty close without having to worry about it. But that would help. Then Matt says, I just go a third up to half up. Makes sense. And do most people out there do it in plane or out of plane?
I do mine in plane, although I will say my own my actual physical PT nerve anatomy, because I have my fellows block me all over the place, is very hard to get to in plane, like the way things sit, and so it would probably more amenable to out of plane.
That's brave, Matt, letting you do all those blocks on you.
Do you let them do it with Lido, or do they just do saline?
Usually just do salines, because by the time, like the last time we did it this past June, I think 6 of our fellows did nerves. And so I had both PTs, I think a full forearm, and then one of our ultrasound fellows on the adult side did a brachial plexus. And so I would have been probably in full on like arrhythmia and stuff at that point, and entirely non-functional.
Yeah, I do. And it's interesting. Fred does a lot of his out of plane, and I don't know if he was emergency trained as opposed to PEDS trained first, but he'll go after his forearms out of plane. He goes for his posterior tibs out of plane. So cool. So those are my cases for today.
Those are great cases, Paul. I had a quick question. Probably do you guys in the group, anyone follow like a certain size for abscess to go after, or if it's just juicy, you don't really care about the size in terms of when to go after one?
Yeah, usually if it looks big enough to drain on the ultrasound, I'll go after it.
Yeah, I usually use kind of a combination of like size, depth, and whether or not it's already started to self-drain itself. For the ones that have already got a little punctum that's weeping, I'll just typically just like give them a little quick poke to help it out. My mental is, a centimeter is sort of the number I'm usually thinking to make it worthwhile for most things, but I don't have like a hard and fast to that.
I don't know if there's any literature saying what size.
There was one paper a few years ago in adults trying to look at what would predict failure. I don't feel like the performance metrics they were able to get were particularly good, but it wasn't a large study number.
Yeah, I think that for the most part, I heard of the 1 centimeter. Like it's not really worth it if it's less than 1 centimeter. Eric from Israel said he doesn't go anything under 0.5 centimeters. So yeah, I was just wondering if there's any sort of size limitation anyone uses.
I'd agree with the centimeter also. My only one caveat, this actually goes to all of your first cases, when I'm looking at the tush, just because I feel like that's an area that's really prime for having isoechoic fluid collections.
Mm-hmm.
And so sometimes I will err on the side of being a little bit more aggressive, only because I've had cases that didn't look like much on the ultrasound and looked like kind of what yours first had, which is a lot of cellulitic changes, and then drains like a lot of pus. I don't know if anybody else shares that experience.
I would agree. I find they're often, I get really aggressive with my squishing back there while I'm imaging to make sure that nothing goes like glistening around on me.
And Rahul just shared an article. It said the size their users 0.4 centimeters. Higher than that, looks like it's worth training. So thanks Rahul for sending that papers in the chat. If everyone's interested. So and there's 162 patients looks like on that paper. But yep, so if there's any other questions or comments, Paul, thank you once again for presenting interesting cases, and thanks everyone for showing up this week. And then hopefully we'll see you all next week.
Thank you.
Just put in one plug that P2 did send out a research survey, so hopefully everybody got it and filled it out. If you haven't gotten it, email Matt or text him so you can get your name on the list.
Yep, I already did it and filled it, so yeah. So thank you everyone.
And Henry, you still there? Peace out.